Thank you. So the title, Don't Believe the Hype, followed by the philosophy of science, is a big deal. The philosophy of science can superficially be something that some people would be like, what do you mean? Why should I care? Well, the philosophy of science is the building blocks of how we go about observing things and understanding things. So there's a few terms that I'll define before I try to say something else. There is ontology, epistemology, axiology, and then the principle of parsimony. So the first three are Greek. Ontology, philosophically speaking, is the study of reality. What is real? In philosophy, you're going to have a dichotomy, or you're going to have two ends of a spectrum. You're going to have those who believe that ideas are the most real thing, and then you're going to have those who believe that material objects are the most real thing. So when you're trying to understand what somebody's talking to you about, especially in philosophy or in science, if you are not able to observe that they're coming from an ideology perspective, or rather an ideal perspective is the more appropriate term, versus a material perspective, then anything that they say can very easily clash or possibly not align with what you think they're trying to say or what you're trying to learn. So just to reiterate that, ideas are the most real or objects are the most real. So the best way to provide an example of that is this water bottle. If somebody believes in ideal or the ideal form, this is not the water bottle. This is a poor approximation of the water bottle. Reality is only in the realm of the forms. This is not the t-shirt. It's a poor approximation of the ideal t-shirt. Versus the materialist would say, this is a water bottle. It meets all the criteria. Can it be used for other things? Sure, but it's a water bottle. This is a t-shirt. It suits the purpose. So it's ideal versus material. Then you have epistemology. To have an epistemology, or a theory of knowledge, or a theory of truth, you have to have a view of reality. So when somebody is attempting to talk to you about what is true, if you don't understand their perspective or their claimed perspective on reality, then you're going to have a hard time understanding what the heck they're actually talking about. Epistemology, you have two ends of the perspective, or the spectrum rather. You have constructivism, which believes that ideas are the most real thing, or it's formed by that. So a constructivist would believe that the truth is dependent on the individual, the environment of observation, and the previous experience of the individual. So if somebody believes in constructivism, or they're using constructivism to identify what is real or what is true, what can be known, and who it can be known by, then you're understanding that it's a relatively narrow truth. It is a truth that is highly dependent on a lot of variables. Whereas on the other end of the spectrum, you'll have a positivist who believes there is a singular reality that can be identified with appropriate experimentation. And the problem is the interpreters. So these are the people who are going to believe more in this is a water bottle, and they're going to study the breakdown of the constituents of this water bottle and how do you make a water bottle, things like that. Whereas the constructivist would say, what does this water bottle mean to the individual? What did it do to their feelings, right? So when you're looking at that spectrum, be it with respect to the study of reality or the study of truth, now you can start to understand what the heck might be going on when you look at claims. So within a lot of healthcare practices, and within some of the discussions that you've heard today, you hear about the value of the patient experience or the patient's perspective. That's very valuable in, say, the therapeutic interaction, because the patient is there. Their experience matters. Their subjective viewpoint matters. As a therapist, however, your interaction, despite whatever you may prefer, is physical. It exists in the realm of shared reality. So I can't treat somebody's feelings because I can't feel them. I can treat somebody's material existence in that I can identify a movement problem and change that movement with appropriate interfaces that are probably going to be informed by the experience of many, right? So you go to a school, you learn particular methodologies and particular viewpoints that have been worked on over time to the point where they're transmitted to you in that shared space. You as an individual then physically enact that with your patient, and that's the shared reality, right? The experience of the patient is that constructivist thing. So as a therapist in that therapeutic interaction, you need to acknowledge that positivist or that shared reality, that singular reality perspective, as well as that individual reality perspective. So sometimes you're going to have a clash, your feelings versus the patient's feelings, what you value versus what the patient values. When you don't have these aligned, sometimes these are the patients that maybe you'd like to consider not having a therapeutic relationship with anymore and trying to figure that out. But that's on one side. So if you're going to form a research question, and you want to know about, say, the impact of massage therapy on the patient experience, well, you can form that question. If you want to know about the impact of massage therapy on the patient's tissues, that's a different question. So the impact of massage on the patient's experience, or hands-on therapy on the patient's experience, that's a constructivist question. That's the individual reality versus the impact of the massage method or the hands-on method on the patient's tissues, be it measured in movement, or be it measured in histological change, cellular metabolism, whatever it is. That's a positivist question. Okay, so at least with respect to attempting to understand things and the claims that people make, you can see that there's at least some value in understanding the spectrum of the beliefs in reality, or the ends of those spectrums, and the spectrum with respect to epistemology, what can be known, how can it be known, and who can it be known by. Then you have axiology. Axiology, the final Greek word of the three, is the values or the value judgment of whomsoever you're discussing. So if I choose to ask about the impact of massage on the patient experience, I'm making a value judgment that the experience is the important thing. So the question that I ask is the value judgment, or that's the evidence of the value judgment, versus if I ask the impact of massage on the patient's tissues, that's a value judgment. I am saying that the somewhat contextually disembodied evidence of the patient's tissues is the more valuable thing, right? So there's value judgments being made all the time. These things are occurring constantly. You are doing them maybe just not as consciously as you could, right? So it's the value judgments. So if you look at research programs, if you care about research, if you understand the view of reality, the view of truth, then you understand the values of the practitioner, the research group. When you understand their values, you can start to understand why they're going after what they're going after, and then you can choose whether or not that's valuable to you. Right? The principle of parsimony is the important one when we talk about what you think as a massage therapist or as a hands-on therapist in relation to what's actually going on and the explanation that you will then give to the patient. So the principle of parsimony is it favors the explanation that explains the most while assuming the least. Okay? So if you are going to say something like your left shoulder is moving with greater restriction than your right shoulder, it would look like this: left shoulder more restricted than right shoulder. The second you say anything other than that, so this is the observation. The second I say it's the latissimus dorsi, right? I'm making an assumption based on my observation. I'm going a layer deeper than I can observe. Now, I can say that based on the fact where it is in the range of motion, that it's most likely latissimus dorsi, right? But I can't say it is latissimus dorsi because I cannot observe it appropriately. If I say it's neurological, I'm making an assumption. If I say it is fascial, I'm making an assumption. I cannot observe the fascia directly. I can observe proxies for what I assume the fascia is doing or the state that it's in. The principle of parsimony has high value with patient communication. Many practices are built on patient communication. Patient communication can include things that are not observably accurate, but highly valuable to the patient. Many will have the experience that you'll see somebody who's very busy. If you observe their technical skills, they may not be exceptional, but their patient retention is exceptional. So now you can see where how I pose the question to figure out what the heck that is has value. So if I pose that question as a constructivist, then I can start to figure out if it's the patient experience and the things that are being communicated to the patient, right? I can also do that as a positivist. I can observe the specific words that are being said to patients, and then I can observe whether or not that is related to patient retention. So I can ask the same question from two different perspectives, but you can see that the practitioner is showing a higher level of value for ideas versus material reality. So you can start to see how this pieces together, but it's the assumptions that are exceptionally important and can cause a lot of trouble that is hard to detect. So most people that are going to make assumptions or provide explanations based on motion findings, they're not doing so maliciously. They're doing so primarily because they've been taught to think with specific details, and those specific details say that this is a fascial restriction, or the specific details that say this is a muscular restriction or ligamentous or whatever restriction. Based on how the movement test went, they then fill in with the details that they've been taught without thinking about the view of reality, the view of truth that they were taught with, or the mix of those views. So if you're not understanding that, then you're taking on these details, you're implanting them into yourself, you are then sharing them with your patient in whatever way that you do. It's that layer of assumption. The moment you go beyond your environment of observation, you are then getting into the territory where weird things can happen. Now, those weird things may be very valuable for your practice, exceptionally valuable, as a matter of fact. If you speak to patients in ways that show you as an authority with these high-minded explanations of what's going on to them that nobody else says to them, so clearly you're the one that sticks out, you're the most valuable one at that point, so the patient can then interpret that. You're not doing that to trick the patient. You're doing that because that's what you think. But if what you think is built on layers of assumptions and you don't know, you're not being malicious, but you're being less accurate than you could be. Now, not everybody's going to value accuracy. Not everybody's going to value getting closer to that positivist truth or that singular truth that everybody could see regardless of their perspective. You don't have to value that. But if you do, then you can see why within hands-on therapeutic discussions, you have these camps that are very opposed to one another. They're within osteopathy. If you look at some research, it was done in Australia. What they found was that the attitudes of osteopathic practitioners within the university system, because it's taught in the university system there, their values are more towards the patient experience as opposed to any mechanical hands-on measurement. So the osteopathic practitioners, at least in Australia, are more concerned with what the patient reports and feels and says than how the patient moves. So a hands-on therapeutic practice is primarily mediated through the physical world in that shared reality. But the practitioners will tell you that they value the patient experience more. So what would that suggest with respect to what they would try to build in their knowledge? They would try to build and shoot for the patient experience. So when they say things like, or when they get into situations where they're talking about craniosacral pulsation or cerebrospinous fluid pulsation, they're talking very, very deep layers. They're making assumptions that you can take that proxy, that physical movement, and interpret it as something that is much deeper and much harder to observe, right? I can't tell you that they're wrong, but I can tell you that their environment of observation doesn't match their claim. But what you will find often is that practitioners that approach that way, they will have good reports of patient experience. So it doesn't necessarily mean on the physical level that nothing is happening. What it means is that the interface isn't lining up with the claim. If I palpate the base of somebody's skull and I say that I can feel a low pressure fluid pulsating, my environment of observation is incorrect for that claim. But the patient reports something positive. So something's happening that's positive. It's just not in the realm that I'm claiming. So if your view of reality has a lot of assumptions in it, but the actual observable reality, the patient experience, is positive, then you can say that they don't line up, but you can also now start to reinvestigate. So myself as an individual, I'm not necessarily the biggest fan of those more esoteric claims, but I wouldn't disabuse anybody of them on account of the fact that they're having positive patient outcomes, but I would have a discussion with them about their claims not lining up with what they're doing. So if your claims don't line up with what you're doing, I can trace you back, or now some of you can trace back through those steps of axiology, so the values, the epistemology, the theory of truth, what can be known, how can it be known, and who can it be known by, and then get that down to the bedrock of the view of reality. So if you can identify whether or not you agree with any of those things, so your values line up with them, your values don't line up with them, your discussion becomes a little bit more accurate, or you line up better in your discussion. And then in the patient encounter, you can start to figure out how you translate what you value into that. But observably, the patient's experience matters. The hands-on shared reality experience also matters. So your way in with the patient is to identify what's not moving, interface with it appropriately. If it starts moving better, then you've done your job on your scale, on that positivist scale, or that shared reality scale. If you talk about any rationale other than it wasn't moving well, now it's moving better, you're starting to make assumptions. So now you need to talk about the principle of parsimony. If it gets moving better and then you ask the patient about their experience and they say it was positive, you have good alignment. If you get it moving better, you ask the patient about their experience and they say it was negative, you don't have alignment. If you, on your scale, you try to get it moving better and it's not moving better and the patient says they feel fantastic, well, the patient wins because their experience is positive. But interestingly enough, you will have this happen. You can measure something, you can take a physiological measurement, it can get worse, and the patient will report feeling better. So what you start to recognize is that these views of reality don't always match up, right? So if you're going to look at somebody's treatment, if you're going to see that they're not necessarily getting the result they claim they're trying to get, and then you say something like, well, you're not even doing what you say you're doing. Yeah, but the patient feels better. So you can see how these arguments happen because you just have a different fundamental view of reality. You're arguing about different things. So at least in the discussions that we all have, if we accept that anything other than superficial claims about motion, either gross motion or yield to pressure of soft tissues, anything other than that has issues with the principle of parsimony. You're making assumptions. You're immediately making assumptions because you're observing from the outside. If you can accept that, then everything else falls into place, and maybe you can have a little bit more pathos for whoever you're talking about. You don't have to be as mad at them because they don't agree with what you agree with. You like fascia, they like nerves, right? You're both making assumptions. You both have a problem. Or if you can see that you like superficial movement and they like a deeper explanation, you can say, oh, we like different things. We're axiologically not aligned. Then you can say, oh, do you value the patient experience or do you value changing movement? If they say I value both, fantastic. If they say I value one or the other, now you know if you're aligned. So you can see that from old Greek terms and one principle, you can start to understand where you are in relation to some of your colleagues and why you fight and why you don't have to. You're all going to try to apply your skills to the patient and have a positive outcome. You just may value a different form of outcome, one more physical, one more psychological, emotional. I will suggest if it's psychological and emotional, be careful because most hands-on practitioners are not appropriately trained to enter that. Also, sort of illegal in most places. You shouldn't be counseling them in most places unless you have a previous designation. Myself as an osteopathic practitioner, no, I shouldn't be doing any psych stuff. It doesn't mean that I shouldn't acknowledge that it exists. The easiest way to acknowledge that it exists and be reasonable about it is to not be a jerk, to listen to my patient and to not undercut anything that they say is valuable. But my work is in the physical realm, right? So I'm going to value that and I'm going to acknowledge the patient. So hopefully with those words, with those examples, with those explanations, you have a better understanding of why the philosophy of science is valuable, not only to understanding research, but to understanding your interaction with your colleagues and your interaction with your patients. So thank you very much for your time and have a great day.